started. Good morning, everyone. Welcome to the last day. So today we'll try to wrap up all the main topics in health economics or economic evaluation in healthcare. So we already talked about how to find or how to ideally find probabilities or rates. We talked about how to find utilities or health effects, how to measure them, and the last main set of parameters are costs. In my opinion, those are fairly the easiest to measure, at least at the first sight, because there's no controversy in what metric should we measure costs. We usually measure them in the local currency, but you still need to think about which costs to include, which to exclude, and that all depends on the perspective of the economic evaluation. So let's first quickly talk about how we value costs. In econ theory, we say that the cost of a resource to society is the value of that resource in its in the second best use. It's a so-called opportunity cost. So for example, from an individual perspective, you may think about, if you have $500, should you spend it on a new iPad, or maybe spend it on traveling? Maybe there are better uses. Maybe you need to, buy a new roof on your house. Things like that. From societal perspective, we may think about the government may be thinking, so should we provide, if we have $1 million in this case, should we put it into vaccinating children? Or the next best use potentially, as an example, could be providing cancer treatment. For many goods, the market price is the same as the opportunity cost. However, that doesn't really work that well in healthcare, and there are a bunch of reasons for that. In healthcare, it may actually be somewhat different here in India, but in many countries, most people are detached from paying for healthcare, at least to a certain extent. Because there's a third payer, the insurance company, that pays for at least a good chunk of care. So that's one reason. Second reason is that people usually don't, unless you're a trained clinician, it is really difficult to measure or perceive or value quality of care. How do you know whether getting a scan using the newest MRI machine or the 2 years old MRI machine? What is the difference in quality? What is the difference in quality of getting care from provider in the city center and provider in just like a mile away? So most people have problems evaluating quality in healthcare. To some extent, this applies to other goods as well, but it is very prominent in healthcare. So when we try to estimate costs for economic evaluation, the first question should be, we first need to think so what's the intervention? What are we trying to evaluate? What's the disease or the health condition in question? And I'm afraid that this will blow up. So can we decrease it a little bit?
This or English?
Decrease. All right. How about this? Good, good. All right. I'm sure my energy will come soon, and I will increase my voice. Anyway, so in economic evaluation, we first have a certain health condition in question and some new intervention. New surgery, new therapy, new drug, new technology. So for that particular situation, we need to think about what are the cost-generating events. Especially important are the short-term cost-generating events, but of course the cost-generating situations that come in the future matter as well. One thing to keep in mind is that the ultimate goal of economic evaluation is to get the ICER. That's the incremental cost-effectiveness ratio, right? And so we're actually interested only in changes in resource use. So for example, if we're evaluating a new type of surgery, well, let's say a new follow-up regimen after a surgery versus no follow-up after the same surgery. We don't really care about the cost of the actual surgery, because when we're comparing these two interventions, the costs of the surgery will appear in alternative A and alternative B. So when we take the incremental cost, they will even out. So we don't really have to worry about that. We really care only about the changes in resource use. And of course, like, we care about the changes in use of healthcare resources, non-healthcare resources, informal caregiving time, patient's time. But whether or not to include these individual items, that depends on the perspective. I'll talk about that a little more in a second. All right, so when we try to identify cost items, we usually categorize them into three major categories: direct costs, indirect costs, and external costs. Direct costs are those that directly relate to the particular procedure in question, or that technology. Indirect costs can be the costs to the society, can be something like loss of productivity, something like that. I will talk actually about them, I will list them in a while. And external costs are those borne by other sectors, and those are really difficult to obtain or estimate. So the current practice usually is to just not include those. If you have good estimates of external costs and good reasons for including them, sure, do that. But chances are that you will not have good estimates of these spillover effects to other sectors. So this is pretty straightforward. We usually count what matters, and having good data is always a problem. But that applies to all of the parameters in the economic evaluation. All right, so I listed the three major categories: direct costs, indirect costs, and external costs. So I'll give you a few examples. So examples of the direct costs would be the cost of the actual procedure, or the actual drug, or the new test machine, new diagnostic test, new imaging machine, all the supplies that come, for example, for a new surgery. You need some tools, some drills, gloves. All those are direct costs that directly relate to the procedure in question. You need to pay for healthcare personnel, doctors, nurses, assistants, technicians. Those also are direct costs of each healthcare intervention. Medical facilities. We also should include direct non-healthcare costs. So for example, when patients have to travel long distances to get the procedure, that is a direct cost of the procedure, even though it would be considered non-healthcare. Childcare costs are certainly another example of direct non-healthcare costs. When, for example, parents have to one of the parents or both undergo a certain procedure and then cannot take care of the child, someone has to, right? So that is a direct effect of the procedure. Indirect costs would be productivity costs, costs associated with lost time in work, lost productivity due to disability that is caused by either the intervention itself or maybe disability that is prevented by the intervention. So the alternative would be to this intervention would be not offering the intervention, which would then lead to disability. So we should consider that as well. Time costs spent by just undergoing the procedure and recovering. And finally, future costs. So when I was reviewing these slides yesterday, I realized that this may be a little bit confusing. So let me pause here. And when we talked about discounting of future costs, that still applies, and all future costs directly related to the intervention in question should be included and should be discounted. What I mean here by future costs are costs that patients incur by extended life expectancy due to the intervention. So for example, if we provide this new drug that increases survival of cancer patients, for example, by living longer, they incur additional costs they wouldn't have otherwise. Because if they passed away sooner without the intervention, they wouldn't have incurred all these costs, right? So this is somewhat controversial, whether or not we should include these kinds of costs. So I will not give you a clear recommendation whether or not to include them. I will leave that up to your own decision. Not necessarily the treatment costs. So the direct treatment costs. So let's say if this patient lives longer but has to be getting, for example, this new drug constantly to just keep that patient alive, that is not as controversial. We would include those. But by living longer, they may have other health issues, maybe. For example, if we're talking about cancer patients, they suddenly can develop, diabetes on top of that. The cost of that, including the cost of that is controversial. So this is what I mean by future costs in this particular case.
Would that be balanced against his productivity also? Because we are looking only at the cost of making the patient live longer. We are not taking into consideration the patient's productivity. So during that time, he's able to do probably 0.50% of his skill only.
Yeah, absolutely.
So that sort of events.
For some patients, if we're talking about the elderly population, not so much, right? Yeah, very good point. Thank you.
If we have carried out a large randomized trial, then that future costs will be almost equally distributed in the two groups, comparison arms, and therefore we can just ignore.
Yeah, if they're equally distributed across the two groups, absolutely. We care only about the changes, about the incremental change in costs and incremental change in effectiveness.
Ethical issues, how we can measure it in terms of cost?
We don't really measure them in terms of costs. It's just the question is, the ethical problem is, should we include these costs, this additional burden to the society that we make by keeping people alive longer? And you can see, like, this really this sounds weird, even just like explicitly say it out loud. So that is the ethical problem here. Like, we don't really measure that in terms of costs.
When we talk about time costs, like time spent waiting and undergoing intervention, and that actually is accounted for in the productivity cost, like when we monetize the time into money value.
Yeah.
Are they usually excluded?
Yeah, they're not. They're not. Very good point. Like, so some of these are overlapping, and if you account for one, you kind of account for the other one.
So we report both? Or?
It depends. So if you have, if you have an elderly population, their lost productivity will be pretty much zero. But they may still incur some cost by just undergoing the procedure itself. While for younger people, or maybe the same thing applies for kids, their productivity also doesn't really change that much. But the intervention may impose a certain burden on them by just keeping them in the hospital and during recovery time.
When you say productivity, you're meaning in terms of their work.
Yeah.
So that doesn't, because for a child, they could be a student, they are in school, university.
Exactly. So, very good point. Children, like, if they're undergoing, for example, a surgery that has a long recovery time, they would miss out on school and would have to catch up at some point, or they would be delayed by maybe a year, and that is a cost. That is a burden, right?
So how do we estimate it? How do we translate it into this?
For the students, I honestly don't know. You would translate the lost productivity by estimating the time the person was not productive because they were just undergoing the surgery and then they were recovering in the hospital, so they were not working. And again, I believe there is some statistical office here in India that provides data on average wage, for example. And so then you can use that, essentially multiply the time spent not working multiplied by average wage.
Can we put this number of school days lost per year?
Yeah. I don't know what would be exactly the cost amount, but the number of school days would definitely be the lost time due to the intervention. Other examples of indirect costs are friction costs. Those are costs associated with replacement of a worker. If a worker is not working, the employer likely needs still someone to get the job done, and that imposes additional costs on the employer. So if we're taking the societal perspective, that matters. Transfer costs, there are some administrative costs associated with changes in general. And finally, fixed costs could be an example of indirect costs. If the hospital needs to buy a new machine every now and then, that should be accounted for. In general, we consider mainly, in most economic evaluations, we consider only variable costs of the procedure. So we somewhat assume that the hospital already has the MRI machine, for example, and we include only the costs that happen only due to the one additional procedure. So we need to pay the technician to press the button or first position the patient in the scanner, press a button. Then we also need to consider the opportunity cost of the scanner, which means that if we decide, for example, if we decide to provide this new screening program, which would mean that all people would get an MRI scan, and we would look for, I don't know, cancer. If we're screening every single person, that means we probably don't have that many machines. There will be long waiting times. And if the machine is scanning for someone or screening someone who doesn't necessarily need it, it means that there may be someone else who really need the machine to be in the machine for other more urgent condition. That will be the opportunity cost of using the scanner.
So would you account for the cost of that machine in MRI?
You mean the fixed cost of buying the machine in the first place?
You will include that.
It depends. In an analysis that's done from even the healthcare sector perspective, but definitely from the societal perspective, but especially that is done with long time horizon, you probably would include this, because all machines have some life expectancy, like they don't work forever. So if you have an analysis that has 50, 60 years time horizon, you would have to buy the machine every now and then. That would be included.
Ideally, the cost of the procedure would include all of those parameters. Right. So, for example, the place where you are conducting the rent or the place, the cost of the overall space, the AC, the lights that you're using, the machine, the staff, payment for the staff, all of those should ideally be included in the cost of the procedure.
Wait, 2 more slides, I think. The short answer is pretty much yes, but we'll talk about different costing approaches. Can you see this? Not very well. This table is taken from the most recent book on recent recommendations how to do cost-effectiveness analyses. It's called Cost-Effectiveness in Health and Medicine. It's written mainly from the US perspective, but the methodological approach, that translates to all countries. And it shows you the comparison of the types of costs that you should consider or should not consider, depending on the perspective. And currently, the recommendation is to, when you're doing a cost-effectiveness analysis, you should do the analysis ideally from at least the healthcare sector perspective and the societal perspective. If you're interested in other perspective, sure, do that also. But these two, healthcare sector and societal perspectives, should be included for comparison purposes across different types of intervention. It means a lot of additional work. So treat this as a recommendation. It's not a requirement. If you're doing cost-effectiveness analysis only for purposes of a particular decision maker, you don't really have to consider all these like societal and healthcare sector perspective. If the decision maker is someone else, then these two types. But if you want to publish the study and essentially contribute good information to the research community, these two perspectives should be included. And you can see that the formal healthcare costs, that is what I called direct healthcare costs, those should be included in both perspectives, healthcare sector and societal. But informal healthcare costs or informal healthcare sector, which I called indirect healthcare, no, I called them, what did I call them? Direct non-healthcare costs. So they already, from the healthcare sector perspective, they already fall out. But non-healthcare sectors, such as productivity, consumption, social services, effects on legal and criminal justice, education, housing, environment, these types of costs should be considered definitely from the societal perspective, but not so much from the healthcare sector perspective.
So the question is that in India, for example, most of the patients stay out of their own. Many programs aren't covered by, many diseases aren't covered by health programs or stuff like that. Then actually, it's not the healthcare sector that's paying for it. Then why not take the patients?
Absolutely. Like if all these recommendations are somewhat general, and if India has a very specific situation, then you should adjust the analysis to your local environment and the local situation. So if most patients pay for care out of pocket, they are the payer, right? So in that case, like, the analysis should be done from their perspective, as long as you're trying to inform their decision. Right? The perspective really is should be decided on whose decision you're trying to inform.
I think, in my opinion, I think it depends on the care seeking of the patient. So if it's care seeking in the private sector, then probably out of pocket would have more weighting. But if they're care seeking in the public sector, then let's say healthcare costing must be known.
Absolutely. Like if it's the public sector, that means that the public is paying for this, right? And there probably is some public government official that makes the decision whether this procedure should be provided or not. And in that case, that is the perspective.
And whenever you are considering individual's perspective, there will be a problem of threshold. What threshold will you take? Because that will depend on the income of the patient. And if it is health sector or government, then it is at least given.
Yeah.
That will be a problem.
So tuberculosis is the best example. When it comes to public health problem, to make patient to take the treatment, government is investing more to reduce the patient cost. If you are not assessing this cost analysis from societal perspective, then you may get 60%. Then other things, the environmental problem. When they cough, it will spread. That cost, I don't know how we can calculate. So again, environmental cost also needs to be included. If you are not including all this factor, then you are underestimating your cost analysis.
I think it depends on the disease. I can tell you the corollary to that. Patients with acute care, like in a heart attack, they're all 70% out of pocket. There's no coverage. Still, data shows that 2017 WHO report says 60% of the patient is still out of pocket. The new schemes have come. 60% out of and only 30%. That's the Indian status. Now it's probably the estimate that they aim to cover at least 100 million population. Might change. But as of 2017, 60% is still out of pocket. And I think TB, and when you consider your analysis, it sort of has to mark in the disease nature.
Yeah.
Most of the acute care are invariably out of, at least what we see from our perspective, is mostly out of pocket.
Yeah, a lot of these, if you do the analysis from the societal perspective, a lot of these problems disappear because you pretty much consider all costs. Doesn't matter if they're out of pocket, if they're paid out of pocket by the patient, or by the government, or by charity, or if they're just borne by the healthcare sector, by the hospital for providing the care for free because the patient couldn't afford it. So it solves one problem, but it introduces many other problems because now you have to figure out all these costs, right? So there are always trade-offs.
Sometimes government will directly interest for that indirect cost and patient cost. because they want to invest, they are worried about their investment?
Technically, yes. At least in the ideal world, the government should care about the citizens, right? So, hypothetically speaking, they should care, and in that case, this should be considered as well. All right. So, more about identifying resources. So again, depending on the particular condition, depending on the particular intervention, think about all the event pathways, which is actually, like when you're developing, for example, the decision tree or the Markov model, the bubble diagram, that will kind of help you guide that. You're already doing that. You're identifying all the pathways where that patients can take, and all the costs they can incur along the way. As I mentioned, perspective is key, because the perspective dictates what costs to include, what costs to omit. In general, this can get really overwhelming, because there are so many costs along the way that can be included. So it's fair enough to exclude some of the, like 1 rupee here, 1 rupee there. That doesn't really matter that much. Usually we care about the large cost drivers, such as hospitalizations, follow-up surgeries, follow-up treatment, expensive drugs. However, if you're excluding some costs that are somewhat obvious, you at least should have a good explanation why you decided to do that. And again, like the future costs, but we already talked about that. So when we prepare cost parameters, we first need to determine what costs to include by category. All those like indirect costs, direct costs. We focus on the big items. We talked about all this. And in the second step, we identify data sources for costing process. I will talk about that on the next slide. Maybe let's go there right away. This goes back to your question. At the beginning of this workshop, I mentioned that whenever you hear the word cost, ask cost to whom? Because the cost of providing a surgery to the hospital is likely different than the cost to the patient if they're paying the full price. Because the hospital will likely include all their costs plus some profit margin, unless they're providing it as charity and then they bear all the costs to them. So this is again another thing that is influenced by the perspective of the analysis. If the perspective is the hospital, then we care about the cost to the hospital, not necessarily at what price the hospital sells these particular services. If we're talking about the patient perspective, then we care about what the patient actually pays. And we don't care about the individual items that individual costs to the hospital, because those are already included in what the patient probably pays. There are two main approaches of costing. One is called microcosting, the other one is called grosscosting, and it's exactly what you think it is. In microcosting, we consider like every single item along the way. So as you mentioned, it includes not only like the actual time of the time and salary of the personnel, for example, doing the surgery, but it also includes the cost, for the AC, for the lights, for the electricity. For all the administrative people who support the healthcare providers. We would include costs for gloves, tools, all these, every single tiny item has some cost. This kind of costing approach is the most precise, but the most tedious. On the other hand, gross costing is the exact opposite. We just take, like, we try to find, like, what is the cost of, open heart surgery, and there will be just one number for open heart surgery. To find that number, that's usually done by the microcosting, by someone else. But if someone else already did that, published it, it's fair to take their estimate and just include, all right, the cost of open heart surgery is this many rupees. So for the if we decide, or if we need to do the microcosting approach to finding costs, data usually come from RCTs, administrative claims databases, or billing systems. Every hospital likely has some billing department and financial department that keeps track of these items. The data quality will likely vary from institution to institution. So data quality certainly may be an issue. Wages would be part of microcosting, so that can be found either by, from the HR department of your institution, or at least from some statistical office, to get a general sense of what, for example, nurses make per hour. When we assign costs, or when we try to find the value for costs, they usually vary geographically, and not only country by country, but even within one country. That goes back to my earlier point that if you find that certain procedure is not cost effective in the UK, it doesn't necessarily mean that it's not cost effective in India, and vice versa. We definitely need to adjust future costs for inflation. Again, perspective. We already talked about all this. For gross costing, it's much easier to measure, but it's just less precise. But it can save you a lot of time. So if someone already published good estimates of certain procedures, I would just use that. If you trust that the estimates are precise enough, it will save you a lot of time that can be spent otherwise. Even your time has some opportunity cost, right? Yeah, we already talked about this. So here's an example of a typical inventory if we decided to do microcosting. So for hospital services, we would usually look into the institution's medical records, and we can measure costs in terms of hospital stays or per visit. I will talk about how to get the price in a second. When we want to measure patient time lost from work, we would probably ask the patients how long they were unable to work, unless we keep the patient in the hospital, and in that case we know how long they were there, ergo not working. So for figuring out prices of healthcare services, this table was actually developed from the US perspective, so I'm not sure how well it will translate into the Indian environment, but chances are that it will. So what we call charges is sort of a list price. That's what the hospital would have on their price list that's published somewhere, and it's a price that the hospital would wish to get, but also you can still negotiate, or usually insurance companies negotiate with hospitals or healthcare providers in general about prices. And the charge, the list price, is usually not what ends up being paid. So the actual reimbursement is what is actually paid by whoever pays. If it's the patient, the insurance company, or someone else, or the government maybe. So reimbursement is what is actually paid. Charge is what is posted publicly, but it doesn't necessarily mean it will be the final price. Variable costs are the costs associated with each additional procedure, but that doesn't include fixed costs of building the hospital in the first place, buying all the machines, and so on. They would be ideally, if you're doing the analysis from the healthcare sector perspective, variable costs would be what you really would like to get, but they're really difficult to obtain. Finally, I don't really know how much this applies here in India, probably not. In the US, there is one national payer. It's called Medicare. It's a health insurance program for the elderly provided by the government. And given that it's a national program, they have a fixed price for every service. So that is what people in the US usually use if they cannot find better estimates of prices of certain procedures. Given that Medicare is national and also public, therefore their data are publicly available, that is a good source of data, at least in the US. I don't know if there is anything similar like that in here. And finally, the main point on this slide is, if there are costs incurred in the future, discount them. Discount them to the present value for both alternatives, because we just cannot compare cash flows that happen at different time points, even though if they're the same. We talked about all that. So finally, we're getting to an example how you could find how two different interventions can lead to differential costs, and how you can then apply that estimate in the gross costing approach. So this is a study that was done by my colleague from Emory, and it was a comparison of inpatient costs per day in general surgery patients with type 2 diabetes treated with basal bolus versus sliding scale insulin regimens. And the objective was to compare the hospitalization costs associated with different insulin regimes for general surgery patients with type 2 diabetes. That's pretty much what I said before. And the effect, this was only a cost analysis. This analysis didn't really focus on effectiveness, because that was already established in a different study. So the purpose of this analysis was to just compare costs, which could then be later applied in a cost effectiveness analysis that would synthesize all the evidence from both studies. The basal bolus insulin compared to the sliding scale insulin regime improved glycemic control, reduced wound infections, and post-operative complications. So, in other words, it was a better treatment. But we still didn't know what is the difference in costs. And the study populations were patients treated at 2 different hospitals in Atlanta. And for this cost analysis, the researchers chose the payer perspective, and and considered costs such as intensive care unit days, physician consults, number of radiology days, all drugs related to the inpatient stay, and number of essentially the length of stay. The researchers didn't have access to the actual payments paid by payers. In this case, for most patients, the payer was an insurance company, but they had access to the charges. Those are the gross amounts that the hospital posted on the website. So even though we're talking about Emory researchers doing an analysis on Emory data, the hospital still didn't want to give them the actual payments they received for essentially not to lose market power. But there are these cost-to-charge ratios that are estimated by other researchers. So to get the actual reimbursements or estimates of the actual reimbursements, it's possible to take the charges, then multiply it by these ratios, and that is a good proxy for the actual costs. Even though the patients were treated from 2007 to 2009, all costs were brought to 2015, which is when the analysis was done, to essentially provide the most recent estimates, or estimates in the most recently valued dollars to the decision makers. But because each hospital stay was short enough, there was no need to discount future costs. They just brought the values to 2015, depending on whether they happened in 2007, 8, or 9. And then they use generalized linear regression models with a log-link. Log-link means that most cost data are, the distribution is very skewed, fairly resembles a log normal distribution. So taking a log of the costs make the data more symmetrical.
I've got one clarification.
Yes.
Is it only the money value which was converted from 2007 to 2015?
Yes.
But what
Yes.
about the increment cost? Say, like if there's a 10% increase of that for the procedure.
10% increase in what?
Every year.
Yeah.
Say like every institution revise your charges by 10%. So will that account, how do you get an average? Do you take an average of all these cumulative where the study was on?
Not really.
How do you do that? So you do a study for 3 years.
Yeah.
And procedures, cost was 50,000. And the second year it became, like say, 60,000, and the third year was 70,000. But when you average per unit cost incurred across this.
So you're talking about increases in nominal dollars or nominal rupees.
Cost incurred, like in terms of.
Yeah.
The
So
10 prices or whatever the prices went up.
if you brought all of them to 2015, you somewhat accounted for that already, because the inflation rate from 2007 to 2008 was something, and from 2008 to 2009 was also, some positive percentage. So by bringing all the costs to one single time point, you adjusted for these just like general changes in nominal prices over time.
That is the generalizable one. So say of a commodity, like a stent price which was 30,000 became 45,000. It doesn't follow the 6% inflation rate. So when you do the generalizability, you are accounting of certain percentage. But this is arbitrary, like over 1 year. It just follows an arbitrary increment.
Yep.
So in that case, how do you?
One option, if you still worried that bringing the data to one time point doesn't adjust for this. You can include in this regression model, you can include fixed effects for each year. Because even though the costs were expressed in 2015 dollars, you still know when the procedure actually happened. So you can have indicator for 2007, 2008, 2009 would be the reference, and that would adjust for these arbitrary changes. All right, I'll skip to the results. These are just some descriptive statistics that total inpatient costs for the BBI regimen were about $23,000 on average. For the sliding scale, it was 25. But if you look only at these two unadjusted estimates or averages, there was no statistically significant difference. But when the researchers adjusted the two procedures, the costs of the two procedures, for the differences in the population, they found that the BBI regime, the indicator for that, this was the estimate, but if we exponentiate, because we're on the log scale, when we exponentiate it back, we get essentially the percentage of the cost of the reference. In this case, the reference was the standard of care, I forgot the name of it, SSI sliding scale insulin. So in this case, it's 0.86. It tells us that on average, the cost of the new treatment is 86% of the cost of the reference treatment. So this new technology, even though it was better, it was superior in terms of effectiveness, it also decreased costs. In other words, we don't really need to do a complicated cost-effectiveness analysis. This is a dominant strategy. Saves money and makes patients better. All right, so this is all I have about costs.